Thank you both. We'll have the interactive case presentation now, and if I may ask Malcolm Wheel to come and talk to us regarding his case interaction.
Okay, thanks for the opportunity to present this case on behalf of the team in Edinburgh under Mr. Walker. This is a patient we managed surgically who had a pneumothorax, aspergilloma, and non-small cell lung cancer, all in the left lung. So it's a 68-year-old man who's a smoker, productive cough with quite significant weight loss and night sweats over about a 2-month period. Presented to the respiratory physicians. Extensive respiratory history, COPD, a previous right vasculectomy, talpuloridesis, and asbestos exposure. Had been treated with TB 20 years before. Clinically, had some features of early clubbing, cachexia, tar staining, and his GP had set him up for a chest X-ray, and that's how he then presented to respiratory. They see X-ray on admission showing changes in the left upper zone and a pacification adjacent to the left heart border. This report we received basically showing consolidation in the left upper lobe, a tumour with some suspicious mediastinal lymph nodes, a background of severe emphysema, some pleural plaques. CT staging was T3N1. Just showing some representative slices that were taken. So the respiratory team, they did bronchoscopy, mass in the apical segment of the lower lobe, did some washings suggestive of squamous cell carcinoma, and also left upper lobe washings grew Aspergillus fumigatus. Contact with the microbiologist suggested itraconazole. Patient was sent as an outpatient for PET scanning. This confirmed a malignant tumour, SUV is 12, inflammatory change in the left upper lobe. Interestingly, the respiratory team reviewed the PET scan and detected a pneumothorax, which hadn't been reported originally on the film. Again, it's a representative image. Respiratory team took the patient in, inserted a Seldinger type drain, initially with some good reinflation. However, the pneumothorax persisted. In fact, the lung went down a bit despite suction, and had to insert another Seldinger drain because of blockage. At this time, we were asked to get involved, and obviously some of the issues we had were not being able to do PFTs due to the air leak. Patient actually performance status was really good, performance status 1. That was the baseline blood gases that were done on air. We asked for a repeat CT scan. It now showed an obvious aspergilloma cavity in the left upper zone, and basically the tumour was effectively hanging. Quite interesting images. So Mr. Walker and myself took the patient to theatre. We did a left pneumonectomy. That was just in the middle of December. Really at the start of the case, we did some extrapleural dissection initially to get in, and we stapled the main bronchus distally quite early to prevent contamination to the other side. We could continue the dissection to the apex where it really was very adherent, particularly to subclavian artery. And we had a slight breach in the cavity there. We performed an extensive washout, and we restapled the stump much lower down and covered that by suturing the adventitia of the aorta to the pericardium. We didn't use any special irrigation solutions, just water. Nose were taken as shown. We left 2 drains, one at the apex and one to the base for possible irrigation. That's just a representative film. So we sent some pleural samples over the coming days, and both these came back negative, so we removed the drains at day 5. The space was beginning to fill. Patient was discharged home. Microbiologist was in touch with the Manchester team and suggested we should continue the itraconazole for at least 6 months treatment. The final stage was T3N1, 1 of 16 hilar nodes within the specimen, fully resected, lots of organisms within the upper zone, upper lobe, on a background of emphysema. We've seen the patient once in follow-up recently, The space has been very slow to fill. There's been significant mediastinal shift. No clinical features of BPF to date, so it remains very well. So I think this case raised a few discussions really about irrigation of the space, how you manage the stump. Also, are these patients for adjuvant treatment afterwards, which is not an area I have much experience in.
Thank you. Any questions for Dr. Will? Any other strategies, Dr. Will, that you could have done in relation to the stump beyond what you did intraoperatively?
Well, yeah, I mean, I spoke to Mr. Walker whether we should use a muscle flap or something else, but he feels unbalanced with left-sided pneumonectomy. He doesn't tend to cover it, and he favoured just bringing the adventitia over it. But certainly I had that discussion with him, but he was reluctant at the time.
Any questions? Great. Well, we're going to wind up for a 5-minute break. Half an hour break. Should we start back at the same time?
3:45.
You start a bit early if you like.
Okay, well, should we meet back up here a little bit early, 3:30 rather than 3:45? Thanks very much.